Good day, my name is Imelda Williams. This presentation will focus on image interpretation of the spine, with a main focus on the traumatic conditions of the cervical spine. I hope that at the conclusion of this lecture, you will be able to consider the mechanisms of injury that affects the cervical spine. Once again, use a systematic approach when you assess the cervical spine radiographs, in particular the alignment on the lateral radiograph. You should be able to distinguish whether a fracture is stable or unstable, and then you should be able to identify some of the common pathologies of the cervical spine. Here's some reference texts. The three main ones that I've used for this presentation, there's the book by Chan, and Chapter 10 focuses on the cervical spine. You'll also have electronic access to Raby's book, Accident and Emergency Radiology, and Chapter 11 focuses on the cervical spine. And again, the image interpretation manual, the pages associated with the spine is pages 189 to 209. I've also included additional textbooks, Bontrager, which is a radiographic positioning book, but if you have any other radiographic positioning book, please use that. And then a useful textbook also is one by McConnell, Ayers and Nightingale, Interpreting Trauma Radiographs. There are different mechanisms of injury that can cause damage to the cervical spine. So some of the forces that can be applied to the cervical spine is hyperflexion, hyperextension, rotational forces, axial compression, distraction, and shearing forces or lateral bending, and then complex forces, which is a combination of different forces on the cervical spine. The alignment of the C-spine is really important, in particular on the lateral view of the cervical spine. So on this image, the orange line indicates the anterior margin of the vertebral bodies. The green line indicates the posterior margin of the vertebral bodies, and very important to assess if there's any steps in the cortex of the posterior vertebral line, as it is closely associated with the spinal cord. The spinolaminar line is the line in blue, and it's the posterior margin of the spinal canal. And then the yellow line is the posterior spinous line. The tips of the spinous processes should have a gentle slope, with spaces should not be more than 50%. If it's greater than 50%, then you should look and see whether there's any possibility of an anterior dislocations. These lines should follow a slight lordotic curve and should be smooth without any steps in the line. The AP view is important, especially if you struggle to show the lower cervical spine vertebra on the lateral view. So the blue line here indicates the edges of the vertebral bodies and the articular pillars, and they should be more or less without any steps. The yellow lines indicate the heights of the cervical vertebra, and they should be approximately equal on an AP view. The green line indicates the joint space, and they should be roughly equal at all levels. And finally, the red line indicates the spinous processes in the middle, and they should be in good alignment. Just be aware with our more elderly patients, the spinous process line could have some minor malalignment. The open mouth view is very important to check for fractures of C1 or C2. So our yellow lines here indicates the distance between the dense and the lateral masses of C1, and they should be roughly equal. And the green line indicates the tips of the lateral masses of C1, and these should line up with the margins of the superior articular facets of C2. To check for fractures, So with the bones, you should check for cortical margins for steps, breaks, or abnormal angulations. Inspect the vertebra for changes to the internal trabecular pattern, for example, see whether there's any lucency or sclerotic appearances. And then the height of the vertebral bodies should be the same at the anterior as well as the posterior aspects. And then finally, Harris rings is found on the lateral view of C2. And it's normal for slight incomplete inferior or superior aspects. However, it's abnormal if the anterior or posterior margins are disrupted. In the open view, check for fractures also for the base of the peg. However, be aware of the Mach effect, which is an optical illusion commonly seen as a thin black line at the base of the peg, which is indicated here with the green arrow. Now moving on to the cartilage and joints, you should check the facet joints and interspinous gaps. As patients get older, there's degenerative narrowing, which is quite common in the adult patients. So the disc spaces should be roughly equal in height at the anterior and posterior margins, and the disc spaces should be symmetric, and the disc space height should also be approximately equal at all levels. Soft tissue is quite important, especially with traumatic conditions. So the prevertebral soft tissue swelling can be an important indicator of trauma to the cervical spine. The nasopharyngeal space, which is at the level of C1, that distance should not be greater than 10 millimeter. The retropharyngeal space, which is from C2 down to C4, and that should be between 5 to 7 millimeter or at maximum 30% of the vertebral body. And then the retropharyngeal space, which is from C5 down to C7. In adults, it should not be greater than 22 millimeter or 100% of the vertebral body. However, in children, should not exceed 14 millimeter. Now, there's various causes for spinal cord compression. Could be due to congenital defects, trauma such as fractures or dislocations, infections, for example, tuberculosis, neoplasms, and this can be primary or metastatic, disc lesions, and then also pressure from benign growth, for example, from osteophytes. When there's spinal compression, this can result in damage to the neuron and nerve tracts. The damage can either be focal or complete, or it can result in vascular compression, which can lead to infarcts. Spondylolysis can cause damage to the nerve roots, and it can result in muscular weakness, paralysis, sensory loss below the level of the lesion, pain at the level of the lesion, and then there could also be bladder or bowel disturbances. Spinal compression requires urgent surgical decompression to prevent permanent damage to the spinal cord. Most benign tumors are extramedullary and can be removed surgically with very good prognosis. A paraplegic can recover if compression is relieved before permanent damage occurs. However, metastatic tumors have a very poor prognosis. Now, spinal injury can be classified according to the mechanism of injury. With flexion, will result in an anterior wedge fracture of the vertebral body. With extension injuries, could result in small avulsion at the anterior superior or inferior vertebral body corner. And then compression injuries can result in a burst vertebral body fracture with fragments propelled into the spinal canal. Distraction injuries, normally the anterior vertebral body height is retained. However, the posterior horizontal fracture of the posterior body and can affect the neural arch. With translation injury, subluxation or obvious dislocation can occur. Now, looking at specific injuries at the levels of the cervical spine, and we start off with C1. The most common one of C1 is a Jefferson fracture, and it's a fracture of the ring of C1, which involves both the anterior and the posterior arcs. What you need to look out for is lateral displacement of the lateral masses. So here we can see the lateral mass of C1, and it overhangs C2. Also an increase in the distance between the dens and the lateral mass of C1. So the main thing is to look for asymmetry in distances, and then also if that is greater than 7 millimeter, it's an indication of a very unstable fracture. Odontoid peg fractures occur when there's injury to the ligaments, and the types of mechanisms of injury can be either hyperextension or hyperflexion. And look for any signs of misalignment. Odontoid peg fractures can be classified into 3 types, where type 1 is quite rare. It's an oblique fracture, which is an avulsion of the tip of the dens. The most common one is type 2, and this occurs through the base of the odontoid. Important to be aware that the blood supply can often be compromised, and then there's a risk of non-union. Type 3 extends into C2 vertebral body, and that is unstable. So here we have the classification, which was classified by Anderson and D'Alonso. And there we can see is type 1, the oblique fracture. Type 2 is at the base of the dens, and then type 3 is into the body of the axis. If we look at this image, you can see that there's a lucency stretching into the body of the axis, and this makes it a type 3 odontoid fracture. Hangman's fracture involves the pedicles of C2, and here this results in anterior subluxation of the vertebral body of C2 onto C3, and also prevertebral soft tissue swelling. So look for fractures in the posterior part of C2, and then also displacement of the posterior spinal line. A burst fracture occurs due to axial compression, so with somebody, for example, diving and the head hitting a rock or something, and is associated with soft tissue swelling as well as neurological damage. It results in a comminuted fracture of the vertebral body, and here you can also see that the posterior vertebral line has been affected, and in the vertebral body you can see that there is a drop in height in the anterior vertebral part, so you've got anterior wedging. And then when we look at the spinous processes, we can see that there is fanning or widening of the spaces between the spinous processes. A hyperflexion teardrop fracture is the result of severe axial loading or flexion. It appears very simple, but it is very unstable. And what you have is a triangular anterior fracture of the inferior vertebral body, and is associated with posterior displacement. So we can see that there's a slight step in the cortex of the posterior vertebral line, and therefore has a very high risk of neurological damage. The facet joints provide stability and guides motion. We have 2 facet joint ligaments, and if these are injured, it can result in either a stable or unstable facet joint injury. This is caused by typical whiplash type of injury through acceleration and deceleration. If it's unilateral, then it's stable, and if both of the facet joint ligaments are injured, it results in instability. So just to give you an idea, so here we have our facet ligaments, and here is a tear of the ligament, and here we have where it is intact. So one on each side. So if one is disrupted, normally it's stable and it results in a unilateral facet joint injury, but if both have been disrupted, it will result in a bilateral facet joint injury, which is unstable. So on the lateral view, we can see that the spinous processes are malaligned. You can also see that there's a forward movement if you look at the anterior vertebral line, and this is about 25%. The other sign, which is very typical of a unilateral facet dislocation, is this bow tie sign on the lateral view, which is created by misalignment of the pedicles. With the bilateral facet dislocation, the vertebral body, and as you can see here, is anteriorly displaced by 50% or more. Clay shoveller's fracture is an avulsion fracture of the spinous process. It normally involves either C6 or C7. It's caused by severe muscle contraction with torn ligaments. This is a stable fracture as it does not involve either the posterior or the spinal laminar line, and therefore would not affect the spinal cord. Now moving on to some of the common pathology. With rheumatoid arthritis, it's important that if a patient has been referred for a cervical spine, to do a lateral view inflection. Things you need to look out for is erosion of the odontoid process, but also C1, C2 subluxation, which you can see on this image. Also disc space narrowing and sclerosis of the vertebral body margins. So with degenerative disease, normally affects facet joints and is quite common in the mid to lower C spine. It's important to note that osteophyte formation, which we can see anteriorly but also posterior, that if these osteophytes become quite big in the posterior aspects, it can encroach on the neural foramina and give the patient some neurological damage. Degenerative disc disease, normally what you look for is a narrowing in the disc spaces, and it can also lead to spondylolisthesis. Ankylosing spondylitis. On an X-ray, you would look out for osteopenia and then squaring of the vertebral bodies, and then the spine becomes like a bamboo because of ossification of the annulus fibrosus, also ossification of the anterior ligaments, and then ankylosis, which is fusion of the spine. Finally, gas in the prevertebral space can occur when there is a ruptured esophagus or trachea. So in summary, consider the mechanism of injury when you look at plain radiographs of the cervical spine, and always remember to apply the ABC systematic approach with the cervical spine. You should be able to identify typical traumatic fractures and pathology, as well as other common pathologies like osteoarthritis of the cervical spine. Thank you.